Fadi?
Do you see my bildschirm, my monitor? I think so. So
At least not yet. Not yet.
Hmm.
Screen sharing, and then
yes, I did it. Okay, we'll see now. We'll start then.
then you usually see several screens and select the one with the red frame is the one you selected.
So Bildschirm, then yes.
Yeah, that looks good now. No.
Okay, now.
For a second it looked good. What happened? Now it's gone again.
Okay, now it's okay.
I don't see it.
We see you.
I am sorry for the.
Maybe Imad, can you also just share the presentation with us?
But I don't have this one.
Oh, they're all three on the same. They're all three in the Dropbox. I uploaded them myself. You don't have access to the Dropbox? Shana, send us the Dropbox. All three are in there.
Mine as well, please.
I just checked this morning. They're all in there. You have it?
Okay. Then.
I just need a minute, sir.
I think now you could see my bill.
Okay, then
Yep.
now it's yours. Yes.
Super.
It's just a little
Finally
bit,
good.
just need some time.
Okay, so now I think you start. You can see my screenshot. Hello, everyone. My name is Fadi. I am specialist in neurosurgery in the Department of Neurosurgery in University Hospital of Saarland. My boss is Dr. Joachim Ortel. So we will start with this case. It was a patient with 52-year-old male. He came to us after he jumped in the swimming pool with a small amount of water while he was under the influence of alcohol. This resulted in an immediate onset of paraplegic symptoms. Upon the arrival of the emergency physician, the patient was found to be in a state of spinal shock, necessitating the administration of catecholamine. The examination, the patient was in an incomplete spinal cord injury, sensory from thoracic thoracic spine 5, motoric from C6. Clinically, we found here biceps and triceps weakness, both sides grade 3 from 5. Both sides have complete hand and hip plagia, and both sides have knee extensor varices 3 from 5, and right side has foot, left and knee extensor varices 2 from 5. Both sides have foot drop and knee flexor palsy. Both sides have a hypostasia of the elbow and hands. And here we see the radiological examination. The computed tomographic scan showed fracture of the vertebral body C6. So we did the surgery. First of all, we did carburectomy, and after that we do posterior fixation with lateral mass screws. Is the post-operative radiological study. Then I will come over to the question to the board. What do you think? What is the main indication and contraindication for lateral mass screw, and what do you think about lateral mass screw in C7? And describe your method in setting the lateral mass screws and potential complication and percussions.
Thank you. It's a good case. I think the first question to me is it possible to do it only from anterior, only from posterior, or you have to do 360 degrees? So Tobias, you're the first one to comment, please.
Thanks for that. You can hear me?
Yes. Yes.
Yep. Okay, I would first like to see an MRI, and I would like to have answered if the posterior ligaments are disrupted. Is this the case?
Actually, we did.
I think we had
directly-
no MRI on this case.
You know,
The problem
Okay.
is on weekends,
Yep.
although we are a university hospital, we sometimes are not able to get an MRI.
That's
So-
right.
Yeah.
So we
I know that
operated
problem.
mid the night, in the mid of the night, and we started this
Yeah.
surgery first of all from anterior, and then
Yeah, so I would have started from anterior also, especially if I don't have an MRI. The reason is if you have a traumatic disc prolapse, which could happen in that case, then you should get that prolapse first. I probably would have done a corpectomy. I probably would have done a cage with a plate. No, definitely would have done a big cage with a plate. And yeah, if I don't have an MRI, I probably would have turned around the patient and do the posterior instrumentation, one above, at least one below, but I probably would have not inserted a lateral mass screw in C7 because usually the C7 lateral mass is not existing. Yeah, so I would, so and yeah, but this is just probably because I don't have the MRI. So not having an MRI is to go the safe way. The safe way is not to provoke an additional prolapse. So if you don't know, if you don't have a prolapse, then you go from anterior first, make it safe, turn it around. So probably, Joachim, to answer your questions, I would not go from posterior alone, maybe from anterior alone, but then I would like to have an MRI before. So if I don't have the MRI, do it 360.
And would you also always decompress from posterior?
Yeah, I think so. Yeah, I think so. I think so.
Yeah, it's a neurosurgeon's perspective.
Yeah.
Wonderful.
Yeah. You know, I think it makes
I doubt
sense
that any
because
orthopedic would agree with that.
I think it makes sense because you don't know what's in the depths of this spinal canal. You don't know it because you don't have an MRI. And I mean, I think this is the situation all over Germany, maybe all over the world, hopefully not, but it's getting worse and worse. And as you said, we don't have the MRI also, not at nighttime. So that's it.
I think we will address the questions from the auditorium from the later on in 5 minutes with the next case. Maybe just then, Atala, what is your thinking about this case? I mean, you might have noticed, Dr. Hassanain, that actually the lateral mass screws, they look pretty much like Atala screws. When you Fadi, can you share the screen again with the last post-op post here?
Yeah, of course, Chef. So I make the presentation. So
the last screen, you see that the head of the screws is very far medial, and this is the only disadvantage of the Atala screw technique, that you have to do the decompression before. You see that here, right? So the head is very far medial, so you might not be able really to address the lateral spinal canal after placement of the screws. Okay, so Atala, what is your idea? Dr. Hassanain, please share us your thoughts. Not responding. Okay, we lost him.
Okay.
Nothing we can do about it. Maybe, okay, then we move on to the last case. Dr. Al-Gamdi.